Hi everyone, I'm Jaya Vishwanathan and you've found the No Brainer podcast where I discuss all things neuroscience in delightful conversations with various experts. I hope you enjoy today's episode.
Hello everyone, welcome to another episode of the No Brainer podcast, and I'm so excited to invite you today to my conversation with Dr. Beth Shaaban, who is an assistant professor of epidemiology at the University of Pittsburgh School of Public Health and the associate core leader of the University of Pittsburgh's Alzheimer's Disease Research Center's Outreach, Recruitment, and Engagement, or ORE core. She integrates epidemiology, biostatistics, neuroscience and neuroimaging, and psychology to study vascular contributions to cognitive impairment and dementia, specifically vascular contributions in dementias, including Alzheimer's disease using a population neuroscience framework. Her research focuses on identifying the promoters of cerebral small vessel integrity to prevent Alzheimer's disease and related disorders, and has included the evaluation of growth factors, physical activity, and vascular risk factor reduction. Her present work includes a National Institute on Aging funded KO1 award, applying a population neuroscience approach to evaluate gender and sex influences on the cerebral small vessel disease to Alzheimer's disease cascade and the evolution of cognition and brain health in people with a history of hypertensive disorders of pregnancy. So she has so many interests, and another interest of hers is in analytic and recruitment and inclusion approaches to enhance external validity, which she'll talk about today. Her aim is to gain insight into gender-related and sex-specific intervention of targets to reduce Alzheimer's disease and promote brain health equity. I myself have the privilege of calling Dr. Shaaban a friend and a colleague that I know through various professional networks, specifically ISTART, which is the Alzheimer's Association's professional society. And I can tell you guys that I have enjoyed every single conversation that I've had with Beth, and I've come away from it kind of having a better understanding of how neuroscience actually works at the population level, which I'll admit was not something I ever kind of encountered through grad school or my research personally. So it's a very eye-opening and kind of new area for me to explore. And so I'm very excited to get started with this conversation. So given your extremely interesting background and the fact that you're a leader in population neuroscience, because, as far as I know, most of neuroscience research takes place at the individual level, where you're trying to map a certain person's or a certain animal's behavior or perception or some mechanisms to its brain, and then kind of come and aggregate it to the group level. So tell us about your journey, how you find yourself in this space, and what you enjoy about your work.
Well, hi, Jaya. Thank you so much for having me on the podcast. It's so great to be here and chat with you, because we do always have the best time talking. Love talking big and wide ideas with you. It's always really fun. So, as you might imagine by a description like that, my training and my background has been pretty meandering over the years, I would say. So a little bit about my educational background. I did an undergraduate degree in psychology, and so that's really where I first started to get exposed to behavior and cognition. And right out of my undergraduate degree, I was really fortunate enough to get a job in research doing neuropsychological testing or cognitive testing with people who were volunteering for research at an Alzheimer's disease research center. And I worked there for a number of years doing this testing. And I decided I wanted to go back to school and advance my knowledge. And I knew I wanted to study public health. So I did a master's of public health in behavioral and community health. And so I really started to get into more community outreach and engagement while I was working at the Alzheimer's Disease Research Center. And I would say I worked a little bit longer before I really got the bug to lead my own research. So I felt while I was working at the Alzheimer's Disease Research Center, or ADRC for short, that I would be able to design and run my own studies, and then I would be able to ask and answer the questions that I had. And I was so excited by that idea. I had a great mentor who was really interested in seeing me do that, and she really encouraged me to go back to school. So eventually, I quit my job. I had this full-time job while I was getting the master's degree part-time. And I went back to school to get my PhD. And so my PhD was in epidemiology. I was fortunate enough to learn some neuroimaging techniques and learn much more about neuroscience while I was getting the epidemiology PhD. And then just for good measure, I got a master's in neuroscience as well. And so I kept, you can see I sort of kept layering on these sort of new aspects of knowledge. And really then it became very natural for me to fuse the behavior, the cognition with the brain and the neuroimaging, and then all of that with, the epidemiology methods. And so that's what population neuroscience really is an expression of my sort of educational and career development, I feel like, which is really fusing these population-based sciences like epidemiology, where we care about public health and the like, with the neuroscience methods.
Wow. So I have so many questions for you about this space already, and I'll try to rein myself in and ask them in an ordered way. But, this is wonderful. So tell us by examples, maybe, some of the ways in which you are fusing epidemiology with neuroscience and some of the research and clinical questions that you work on in your lab.
So I think that, neuroscientists have a lot to teach epidemiologists, and epidemiologists have in return a lot that they can teach neuroscientists. And so I think it's really a match made in heaven when you're studying things about the brain that might be relevant for public health. So things like dementia. So I work on Alzheimer's disease and related dementias, and it's really only recently that we've started focusing more on dementia as a public health problem. And I would say that historically, neuroscience studies, as you mentioned at the outset, have very much focused on an individual level and very detailed mechanistic characterization of an individual, and less so on large numbers of people and drawing inferences out to sort of a population level.
Yeah.
But it's interesting with something like a disease where you will want to prevent it or control it at the population level. You want to really be able to know that in a larger group and in diverse groups who might be different from one another. And so the ways to do that are to really help neuroscientists understand more about how to design studies such that they can draw inferences, make conclusions about people in the general public, and not just maybe some very highly educated people who tend to volunteer to come into specific research studies.
Right.
And then furthermore, back, maybe 2 decades ago, it used to be pretty typical and okay to talk about psychology research without really mechanistic understanding with neuroscience. And so largely also epidemiology studies looking into, mental health or cognition. There may not have been such a detailed understanding of the neural and brain underpinnings of that.
Yeah.
But now it's really, really critical to bring in neuroscientists and psychologists and so forth into epidemiology studies when the diseases of interest, are around the brain and the central nervous system.
Yeah.
And so I think it's this nice dialogue that we can have back and forth. So what, study design features that may come up are a large observational study that you typically see done in the epidemiology space, having a neuroimaging sub-study that is added into it in a smaller group of people. Some analytic methods that might be added into a study would be ways to weight that sub-study, that smaller group, up to the larger study to look more like the participants in the larger study, or to weight them up even further to look more like the full population that's of interest for your study.
Right.
And so I think there are these nice study design and analysis features that can be used to make neuroscience research more applicable to public health.
Right. So that's fascinating. And, when you say epidemiology, I think for me, at least before I met you, and for a lot of people, like you go to communicable diseases, you go to like things like COVID, you go to the pandemic, you go to like colds and viruses, and you don't think specifically of non-communicable brain disease as some kind of epidemic. And so, at least, I think that's a little bit of a novel idea for many, including me, before I met you, or when I met you. I was like, oh, that is such an interesting way to look at it. And so, can you talk a little bit, just out of curiosity, about the differences between how you would approach, at the population level, something that's communicable, that's actually transmitting from person to person, versus something that is happening in a community because of shared causal mechanisms, maybe because maybe that's a low income area or something like that. So how fundamentally different are these applications of epidemiology?
Yeah, so there is a whole field of epidemiology that deals with chronic diseases or non-communicable diseases. And so there are many epidemiologists who study things like cardiovascular disease or things surrounding, pregnancy. So there are many different specialties of epidemiologists. And epidemiology is really the study of the distribution of disease, the prevalence and the risk of disease, and how that's occurring differently in different populations, different places, and then the risk and protective factors for those. And what I really love about epidemiology is that it always makes me feel like a bit of a detective, and I like that so much. So you're really wanting to ask yourself some questions about who, when, where, why might patterns that you observe in disease be different. And so, for example, we were talking at the very beginning that some of my interests are surrounding sex and gender differences. Yep. And so we note that there are some sex and gender differences that are relevant to Alzheimer's disease. And so the first thing is that women seem to be at greater risk of Alzheimer's disease in later life than men are. And so this is a very fascinating area of research. Some of it seems to be due to the fact that women live longer than men, but it doesn't seem to be the whole explanation. And certainly there are some different factors that women are exposed to than men. And so making an observation such as that, why are women getting Alzheimer's disease and related dementias more than men, is an interesting epidemiological question that might lead you to some of the causal underpinnings of the disease. Right. Or that's what we hope. So the models that are used for thinking about infectious disease are different than what we would use to think about non-communicable diseases. And I'm not an expert in those models, but we saw a lot discussed about that during the COVID pandemic.
Right.
But in looking at diseases like Alzheimer's disease and related dementias, we do look at a variety of factors that are biological, medical conditions that may be occurring in individuals, or other factors that might be social and structural factors that people might be exposed to that might be different in different groups of people, as you mentioned, with income or education or stress exposures that might vary by groups.
So thanks for clarifying that. That is very interesting. So I think it leads us nicely into my next question, which is, can you talk a little bit more? I'm very interested in your research about what you call common comorbidities of aging. And also, when you talk about those, can you also talk about a little bit more about, how you try to uncover these in different populations and what insights can be gained? I know you alluded to it just now, talking about the sex differences piece in and of itself, but then there's also, I know you work on like vascular contributions and some other things. If you can expand a bit on that, that would be great.
Absolutely. So this is another area where neuroscience research has typically not necessarily focused so much on these common comorbidities in aging. When folks have done neuroscience studies, oftentimes the groups included in the studies have been young, for example, undergraduate volunteers from college, or they all tend to be relatively healthy. But obviously in the work that I do, I'm looking at people who are older, and that necessarily means that they've had a lifetime to accumulate some multiple chronic conditions oftentimes, that they've been exposed to health conditions over, the whole course of their life. So they've built up potentially a lifetime worth of risk. And so I think this is something that's really, really important for us to take into account in our studies, is how these conditions, medical conditions and age itself may be co-occurring within people in a way that increases their risk, reduces their ability to sort of bounce back and be resilient to diseases and to other chronic conditions that may come their way. So for example, some of the things that I tend to study are cardiovascular exposures that lead to vascular contributions to cognitive impairment and dementia. And so these are things like hypertension and diabetes. And as we talked about a little bit at the beginning, some of my current work is involving work as a co-investigator on a grant looking at a group of women who are about 10 to 15 years after delivering a baby. And some of those women have experienced hypertensive disorders of pregnancy or other adverse pregnancy outcomes. And so looking at then the way that these past exposures or diseases sort of add up and increase risk over a person's life, I think is actually really, really important. And there's an interesting, there's an interesting field of neuroscience for people who may be interested in it as well. That's health neuroscience. And so that explicitly gives a nod to the fact, that we may be interested in the brain for health reasons.
Yeah. So that's very interesting to me. And I wonder, because there's people who have risk for Alzheimer's disease, but I'm also very fascinated by the centenarian group. And for people who might not be familiar with it, it's people who live to be over 100, but they're healthy, they have no memory issues, they have the cognitive ability of someone like 20 to 30 years younger than them, typically. And so would epidemiology research or population neuroscience research also shed light on what are maybe some of the resilience factors that can help us live a long and healthy life?
Absolutely. And there are great studies being done right now looking at that.
Okay.
And so I definitely think it just involves a little bit of a maybe sometimes philosophical or conceptual shift, which is to change our negative framing of things into some positive framing. And yes, it's really important. And I think the average person who tends to be relatively healthy does want to know, what are the good things that I can do for myself that help protect myself? And so I think of that in two ways. There are two pieces to that puzzle. One is something called resistance. And so that's the idea that somebody might resist disease or bad changes in the brain that are coming along altogether, and they may never experience those bad changes. And then the other piece is resilience, which means that a person may be exposed to some of these bad changes in the brain, but may never show symptoms of them outwardly. And so somehow they're doing something really wonderful within themselves to compensate and not show any outward negative consequences, despite having changes in the brain consistent with other folks who may go on to develop dementia. So
Right.
resistance and resilience are two very fascinating aspects that, if we just flip how we think about things from this negative direction into a positive direction and a strengths-based direction,
Right.
it's very fascinating to think about. Yes.
Yeah, absolutely. You recently published a fascinating commentary on dementia prevention. So from a population-based public health perspective. So can you tell us a little bit more about this approach for dementia prevention? I, again, will admit that this is not something I'd heard of before I read your perspective.
Yeah, and I think that preventive efforts, so taking sort of a public health approach and thinking of preventing dementia, is a way where we can think both about reducing bad exposures and increasing these good exposures that might help us to promote resilience and resistance, like what we were just talking about. So yeah, I was asked to write a commentary that was a response to a very fascinating paper by Dr. Timothy Daly, in which he was talking about something he called the iceberg of dementia risk. And he was basically saying that individual level factors, health behaviors, exposures, are the tip of the iceberg when it comes to preventing dementia, and that there's a whole lot of the iceberg underwater that's really more social and structural and deeper, and needs to be attended to when we're thinking about how to prevent dementia. And so I wrote this piece in response to that, and to try to think about his arguments and how I might extend those arguments and think about that a little bit more. And so his piece, I believe he's a philosopher, which I think is a really fascinating background, for somebody doing Alzheimer's disease research. And so I was coming at it from an epidemiology and public health perspective, and it called to mind a very famous piece in epidemiology that talks about the fact that focusing on individuals who are at high risk of disease and trying to prevent disease in them only will not be able to prevent as many cases of the disease as if you try to focus at a population level and shift the risk of the whole population downward.
I see.
Does that make sense?
Yes, it does. At least, it makes sense, a lot of sense to me. Yeah, you're advocating for reduction of risk across the board.
Across a whole population, rather than simply identifying the people who have the highest risk and trying to remove their risk factors so we prevent the disease among them.
Yeah.
And And it actually starts to point out that then we really need population level interventions, and that the majority of our efforts up to this time have very much been focused at the individual level.
Yeah.
And, they're the types of things that can be done when someone goes to their doctor's office for a checkup and has their blood pressure checked or their cholesterol checked and is counseled on, reducing any of those risk factors or taking medications to treat them appropriately. However, some population level interventions that might be of interest. One that I talk about is, for example, making policies that put bike lanes into a community, for example, to make it safe for people to exercise, to make it safe for people to use biking as a mode of transport, and so on. And that might increase people's physical activity, which reduces risk of dementia and improves brain health.
Yeah.
So these are the types of ways of thinking. Population level interventions are often policy-based approaches that then can be implemented and require much less individual judgment and decision-making on a day-to-day basis from a person, because they're implemented across a community.
Hey everyone, hope you enjoyed this episode of the No Brainer podcast, and see you at the next one.